Dr. Bifi Joy is presently professor of dermatology in Kannur Medical College, Pariyaram, Kerala. He is a very talented teacher as well as a good organizer. And he has organized many conferences, and the first PG Con in South India was organized by him. More than that, he is a very good person as well as a good academician. Regarding the topic which he is going to deliver, is a very important topic which usually in postgraduate studies we may ignore or will not give that much of importance. But going through the various aspects of mastocytosis, it's a very interesting disease with varied manifestations, and it has got different treatment strategies. And diagnosis of urticaria pigmentosa is very easy, and every dermatology student will easily make a diagnosis. But if it comes to a systemic mastocytosis or diffuse cutaneous mastocytosis, there will be some problem. Anyway, Dr. Bifi Joy will give a beautiful lecture on mastocytosis. And over to you, Dr. Bifi.
Thank you, Criton, sir. I hope I'm audible.
Yeah.
Okay. Thank you. Thank you again, Criton, sir, for this wonderful opportunity to have me again on this All India PG webinar. I would also like to put on place my thanks to the Gloderma and Naveen for giving me all the logistic support. So without further ado, I will move it. Mastocytosis as a definition would comprise of a rare heterogeneous group of disorders where there is a clonal proliferation of mast cells. Now here what happens is that you do not have a normal proliferation, you have actually an abnormal expansion and activation and accumulation of tissue mast cells in either one or multiple organs, and skin is the commonest one. And luckily when you have only skin lesions or when you have skin changes as part of mastocytosis, usually the prognosis is good. So what we are worried more is if there is an associated systemic involvement. The prevalence, if you look through the literature, there are various prevalences which are given, but in Asian population, they say it is less than 1 in 3 lakh. So that is supposed to be considered as very rare. But there are certain communities in which they say that it is even seen at a rate of around less than 1 in 10,000. Now, there is a bimodal age distribution for mastocytosis. There is a bimodal age distribution. The first is in the initial 2 years of age, and then in the 20 to 40 years of age. However, we see plenty of cases in the childhood also, because most of the time, since these are not very severe and all, they usually present during that time. Parents usually bring the children during the in-between age of around maybe 2 to 10 or 2 to 15 also. But most common age distribution that is given is from birth to 2 years and from 20 to 40 years. There is no sex predilection as such. Both males and females are equally affected. But literature says that if males are affected more in the elderly group, in cutaneous mastocytosis, there's nothing with the sex predilection. But if the males are more affected in the elderly group, then there is a poorer prognosis when compared to the females. Now, since we are dealing with mastocytosis, I think what we need to know is a little bit more about mast cells as such, because that is a fundamental cell whose proliferation is what we are discussing. So we'll have a few slides on what is a mast cell and what are its characteristics and how you stain it and how you identify and all. So mast cell is otherwise called as a mastocyte or a labrocyte or a eosinophilic granular cell, EGC. Now this eosinophilic granular cell is often referred to the mastocytes when they are seen in the bones. So if you see, when you read something on the bones and osteology, if you see cells called EGCs mentioned or eosinophilic granular cells, they are actually the mast cells which are seen in the bones. Now mast cells are fundamentally residents of connective tissue. They are actually granulocytes which are derived from the myeloid series in the hematopoietic system. Now, even though they are derived from the myeloid series and they are fundamentally granulocytes, they are different from the leukocytes in the sense that leukocytes are slightly short-lived, while mastocytes usually their lifespan is a little more. And I think most of us identify mast cell with allergies, anaphylaxis and all. But in addition to that, actually mast cells have a huge role to play in multiple processes in the human body. It has got a very crucial role in innate immunity because there are a lot of cytokines and growth factors and different mediators which are elaborated by the cell. Plus, they do have a role in the neuroimmune response also. They have a role in the brain immune axis too. And they have a role in tissue repair too, especially in angiogenesis, remodeling, and all. Now, the human mast cells are basically of three types. One that is depending on the presence of tryptases or kinase. So you have one thing which is called tryptase positive human mast cells. You have kinase positive mast cells, and you have tryptase kinase positive mast cells. Now, how you identify between these is that why the importance of knowing this is one is based on the fact that these are the enzymes which are essentially there. Secondly, that many of time in your literature, you get the abbreviations. You get MC for mast cells and you have a connotation with it. So sometimes it will be MCT. So that will be tryptase positive mast cells. Sometimes it will be MCC. So it will be kinase. And if it is MCTC or MCCT, it is tryptase kinase positive. Now, this is a very ubiquitous cell. So it is seen in multiple sites. It is seen at various sites, but the classical sites which are mentioned are the sites or the portal of entries into the various systems like your GI, your respiratory, and your aerodigestive tract. So the common sites are the mucosal surface of the gut and the lungs, especially the pulmonary alveoli. Then you have the dermis of the skin. Now, this is one area in the skin. So, as far as we are concerned, this is the area where mast cells actually predominate. And in the dermis, where the site where it predominates is around the blood vessels and the appendages. Appendages, especially in the papillary dermis, while vessels throughout the dermis. In addition to these areas, it is also seen in the choroid plexus of the brain, the vascular bed of meninges, also seen in skeletal muscles, the oral mucosae, conjunctiva, kidneys, and the entire reticuloendothelial system, including the bone marrow, the liver, spleen, etc. So actually, if you look at it, it's a very ubiquitous cell seen in most of the sites of the body. Now, a little bit of a note on the historical timeline, because I think that is something which you should also know. Probably it will keep the learning interesting. And when you look back, you can see how wonderfully things have gone through, how cells were described before without actually knowing what the cells were, and later their description came up. So the first description of a cell resembling mast cell was way back in 1863 when von Recklinghausen actually described the granulated cells in the connective tissue. But the seminal work was done by Paul Ehrlich in 1878. And he identified and he actually named the mast cells. And this name, mast cells, comes from a German word called Mastzellen, which means feeding or nourishing. Now, Paul Ehrlich actually considered these cells to be nourishing cells for the other structures in the connective tissue. So this is a little bit of general knowledge, and this might help you maybe in some of the quizzes that postgraduates usually get across. So 1878 is a very important year. Then 1937, the fact that mast cells are rich in heparin was told or was elucidated by Holmgren and Wilander. In 1947, our independence year, Roca Silva actually found out that mast cells release histamine and heparin during anaphylaxis. Riley and West then in 52 found out that histamine is not seen scattered in the cytoplasm, but there are certain granules in the mast cells which contain histamine. And mastocytosis per se, the seminal work was done by Kitamura and Co. in 1977, where they found out the tissue mast cell expansion. History, there is a paradox. I think that also you can probably remember that the first description of a disorder simulating urticaria pigmentosa or mastocytosis was by Nettleship and Tay, and this was in 1868. Now, the paradox is that it was 10 years before Ehrlich actually named or described the mast cells. So, a mastocytosis similar disease was described in 10 years prior to mast cells. Okay, going away from the history and coming back to the subject proper. Now, the functions of mast cells are, as we all know, it does play a very important role in allergy and anaphylaxis. But there are other functions also. They are actually the sentinels at the body's different portals of entry within the mucosal membranes. As I said earlier, in the respiratory, digestive, even the urogenital system. And innate immune response is one thing which is mediated by mast cells through its various form. And the cell which actually mediates is the tryptase positive MC or the MCT. And the wound repair is actually modeled by your tryptase kinase. So MCTC is the one which is responsible for wound repair and angiogenesis. I put up two images. These two images actually show how far the mast cells actually influence those two. The first image actually has got a receptors, plus on top of that, it shows what all cytokines are elaborated. These are images which are there in your classical textbooks. You can actually look through. I just put up these two just to impress upon you the fact that mast cell does play a lot of importance, has got a lot of importance, and does play a very pivotal role in a lot of immunological as well as other body mechanism processes that goes on in the daily day-to-day basis and even in disease process. So much so that you can see that each one or each of these roles could be one of the areas where newer drugs, newer interventions can be envisaged in future so that maybe treatment can be aligned in such a way that mast cell processes are actually addressed so that the fundamental disease is. The second slide is the one which I want you to look to a little more carefully. There is a mast cell and you see that there is a degranulation, and from the degranulated mast cell actually there is multiple secretions. You have histamine which mediates the allergy part, you have the eicosanoids, you have the proteases, you have the cytokines which actually go into the different immune process. I'm not going to detail of that because our topic is fundamentally mastocytosis. So I just wanted to highlight how far mast cell is important in both pathology as well as the physiological immunological reactions. Now, how do you identify? The classical one is the metachromatic staining. I'll go a little bit about metachromatic in the next slide. Then the definitive diagnosis is by the immunohistochemistry using the CKIT or the CD117, which actually clinches the diagnosis. Then staining with carboxypeptidase A3 and demonstration of surface bound IgA also acts as a corollary to the different identification process. We'll go a little bit on a note on metachromasia. So I think all of you know how staining occurs. Usually when you stain with a particular stain, the cell usually takes up the original color of the stain. Now, metachromasia refers to when the tissue takes up a different color from the original color of the stain. So a blue color of a original stain might not be taken up, and what will be shown up will be a reddish or a purplish or a violaceous color. Now, what is the reason for metachromasia in mast cells? The secretory granules in mast cells actually release the acidic heparin, which will stain alkaline dyes like azure or toluidine blue to a different reddish purple color. So here there is an acid-alkali action which goes on due to the polyionization, and this actually takes up a stain, but it reflects or it shows up a different stain to the original color. That is so the classical example is the toluidine blue staining. It will give a different reddish purple blue. I think you can in the image see that the toluidine blue in a normal case gives a bluish staining, and that is the lymphocytes which are taken up the stain, and this staining is called orthochromasia. So that is an orthochromatic stain. While on the other hand, you see the mast cells which are slightly more purplish. You can see probably a slight amount of reddish hue to it. So that is the metachromasia that occurs in this thing. So the same stain gives two colors. So when you have a metachromasia, you need to strongly diagnose a case of mast cell proliferation or mastocytosis. Now from this we come back. So this is something about the mast cells. So you have a mast cell which is there, which is a very important cell, which is there in plenty in your dermis, concentrated around the macrophages, but it is usually normally proliferating. And there is on top of the mast cell, there are certain receptors which are actually giving an inhibitory influence to the excessive proliferation or abnormal proliferation. So your CD117 and all act as a protective reflex. They don't allow mast cells to elaborate too much. But what happens in mastocytosis per se is that there occurs a mutation which causes a gain of function mutation instead of a loss of function. So what happens is there occurs a gain of function mutation of this CD117, which actually causes an abnormal proliferation. And mind you, that is a ligand independent also. If it was ligand dependent, then again, there would have been another checkpoint. But here, being it a ligand independent, the proliferation goes on unabated and it goes on continuous. And on top of that, this gain of function mutation also confers a property to the cell to bypass the process of apoptosis. So the programmed cell death also does occur. So the mast cell survives for a longer period, as well as the mast cells are proliferated a lot. So now coming to mastocytosis per se, a little bit about the clinical things. Mastocytosis, as I said earlier, no sex predilection as such, even or if it males are affected more in the elderly age group, then the prognosis is only poor. Then the prevalence is relatively rare, and age there is a bimodal, but it can occur at any age too. Depending on the site of involvement, you have two types of mastocytosis, cutaneous and systemic. The predominant one is the benign type, which is the cutaneous, which is 80%, and systemic, which is only 20%. Among the cutaneous mastocytosis, even though we tell systemic 20%, you need to understand that this systemic could be systemic alone or systemic with the cutaneous involvement. So in general, if you ask, purely cutaneous will be 80% and systemic will be 20%. So if you take cutaneous in total, it would be roughly around 90% to 95%. Now, cutaneous mastocytosis, the classical subtypes are urticaria pigmentosa, telangiectasia macularis eruptiva persistens, diffuse mastocytosis, and mastocytoma. Of this, the commonest is urticaria pigmentosa. The others are relatively less common, and mastocytoma is the least. But what you need to understand now is that since there is so much of change going on in the literature, the recent literature actually doesn't identify urticaria pigmentosa as such, even though they say that this can be urticaria pigmentosa. The terminology which is being used for that is maculopapular cutaneous mastocytosis, and they are putting urticaria pigmentosa as a prototype. Similarly, the telangiectasia macularis eruptiva persistens has been removed. They are not using the term again. They are using a term called telangiectatic cutaneous mastocytosis, which is very rare. And diffuse mastocytosis is there when the lesions are multiple and plenty. Mastocytoma can be solitary or multifocal or multiple. So that is what is cutaneous. So what you need to remember is that when you look through the literature of mastocytosis, maybe you are not going to come across even urticaria pigmentosa. You might be coming across maculopapular. But you need to understand that what they are referring to is the traditional urticaria pigmentosa, which we always say. Now, the systemic mastocytosis is broadly divided into three. Again, luckily, if you look at the percentages, the commonest is the one which is the best prognosis, which is the indolent mastocytosis, referred by the abbreviation ISM. Then, which also has a bone marrow mastocytosis as its part, but this indolent mastocytosis means it has got a relatively less severe course. It goes on for some time. But one thing you need to understand is that once you have a systemic mastocytosis, because of the extensive involvement, the morbidity is quite high, and on top of that, the 5-year survival rate also is relatively less. And if you look at it, I'll tell you the 5-year survival rate. The indolent mastocytosis has got the best. Then you have the smoldering mastocytosis, which remains latent, but it has got its own stages of episodes of severity in different systems. And at times, very rarely, it can progress to the aggressive or the advanced mastocytosis. Now, this aggressive or advanced mastocytosis, this aggressiveness not just occurs because of the elaboration of the mast cell, or the mast cell tumor burden. It occurs because most of them are associated with either associated with hematological malignancies or hematological neoplasms or myeloid proliferations of non-mast cell lineage. And the complication or the aggressiveness or the severeness is because of those two entities. And under these comes the very severe forms of mast cell sarcoma and mast cell leukemia. Now, among mast cell leukemia also, I just would like to point it now itself so that if I don't miss it later on, there is an entity called leukemic mast cell leukemia, where the smears or the blood doesn't show that much of abnormal or malignant mast cells. Fine. So you have indolent, smoldering, aggressive. And as I said earlier, the prognosis differs. Now, a rough sort of percentage that is given is in indolent mastocytosis, the 5-year survival, the usual survival or the general survival rate that is said so is roughly around 4 years to 4.5 years. While in smoldering mastocytosis, But that is said to be a little higher on sense. There are centers where they usually survive a little more. The smoldering mastocytosis is roughly 1 to 2 years, and the aggressive mastocytosis around 6 months at the most. So if it's an aggressive mastocytosis, quite unfortunate. Now, these are the things which are there. There are the multiple classifications. I think all of you would have conventionally known the Metcalfe's classification, which has got all the other things. But the WHO and international consensus classifications have come up in a long way. There are multiple classifications. There has been classification in 2000, 2006, 2008, 2016, 22, and 23. The 2008 classification is relatively taken as a what you call template. So that is where, as I said, you have the cutaneous mastocytosis, where the maculopapular cutaneous mastocytosis, your urticaria pigmentosa is not mentioned, but that is the maculopapular. Then you have the mastocytoma, which can be solitary or multiple. The diffuse cutaneous mastocytosis, and the systemic mastocytosis, you have the indolent one, then the smoldering one, which is actually revisions are all there. At times they are accepted and not. Then you have the systemic mastocytosis of various types, which are aggressive. That is with associated non-mast cell disease type, which is by the abbreviation HND, aggressive systemic mastocytosis, mast cell leukemia, sarcoma, and extracutaneous mastocytoma. The other slide actually shows the different leukemias or myelodysplastic syndromes, which are, pardon me, which are associated with the systemic mastocytosis. You have your myeloid leukemia, lymphatic leukemia, eosinophilic leukemia, everything connected with that. There are multiple classifications. I have not put up everything because that would actually make these slides a little very crowded and too confusing. So you just need to look up. All you need to understand is that this is one area, a lot of research is going on, a lot of deliberations are going on, conferences are dedicated to mastocytosis and all, and lots of consensus go on. So this is going to change every now and then. So keep yourself updated, look into the literature and look for what is happening in mastocytosis. Classifications change, treatments change, newer and newer things are coming out about mastocytosis. So this is basically the classification which I'm doing. The clinical presentations, I think most of you would have seen what is the maculopapular type or the urticaria pigmentosa, where the parents usually bring children, or maybe 6, 7, or 8-year-old children coming with pigmented lesions on the body or pale lesions on the body with history of probably urticarial what you call rash developing over the lesions at on certain triggers on interview. So the classical presentation of urticaria pigmentosa is with either reddish or brown or pale or tan, monomorphic macules, papules, or nodules. I put nodules because there are certain entities, there are certain case reports which have said papule or nodules also. But I think nodules should be considered a little different. And even newer consensus say that nodular mastocytosis is a total different entity from the urticaria. So probably you can shift off the nodules again, but macules and papules and sometimes papular nodules. Importance, they are symmetrical. They affect any part of the body. Trunk is a predominant one, but usually spare the head, face, palms, and the soles. There are instances where you get other types of lesions also. You can get bullae, especially tense bullae. How you differentiate from bullous pemphigoid and all is that if you actually look into the what do you call the Zang smear, you are not able, you won't get any of those eosinophils or any of the other cells. You'll probably see spindle-shaped or oval cells. And with that suspicion in mind, you can actually do a metachromatic staining, and that staining will give you evidence of mastocytosis. Photosensitive rash is a common accompaniment, and mastocytosis, cutaneous mastocytosis can also present with other conditions like flushing, pruritus, alcohol intolerance, heat or cold intolerance, and systemic associations with that could be recurrent diarrhea, headache, and all. So a patient can present you with recurrent diarrhea and headache. When you ask a history, you can probably get features of suggestive of mastocytosis and investigate in that line. And these conditions, they have what is called as a prototypic positive Darier sign. I'll come to that a little later. I'll share an images of one of the patients which we have seen. We had patients presenting with generalized flushing only, which we have considering a possibility of mastocytosis and all. The workup is still going on, so I'm not putting up that particular image. On the other hand, this is one patient whom we had. The patient actually presented with these lesions. You can see the multiple 4 images. The first image on top actually shows a slightly hypopigmented reddish brown macules. And you can see a few lesions on the other, which shows plaques on this. Now, the good thing about a plaque is that usually when you see a plaque, you might think that it's got a little poorer prognosis when compared to papule. But literature and experts say you have a plaque lesion that has actually got a good prognosis, especially plaque lesions in children. So this is a good prognostic sign, and the child is doing reasonably okay with antihistamines and not taking any other specific therapy. Now, what is Darier's sign? Now, we had gone to Darier's sign before. And now, Darier's sign is a specific, relatively specific sign. I can only say relatively because it's not 100% specific. You stroke the skin across the lesion. It will elicit an urticarial wheal over the skin lesion. Now, the importance is that similar sort of urtication can occur in dermographies or dermatographies, or what we call as skin writing. But how you differentiate between is that if you stroke across the lesion, in Darier's, only the lesion will show an urtication or urticarial wheal, while the other part remains normal. While in dermatographism, the entire stroked area will actually show urtication. So that is how we actually differentiate between the two. But it is by no means Darier's sign is 100% specific. It is also seen in other conditions where you can have an elaboration of mast cells like juvenile xanthogranuloma, acute lymphatic leukemia in neonates, in histiocytosis X, in different lymphomas, etc. Now, one of the things that you need to remember is that patients, when they come to you with an urticarial lesion, you need to look for triggers, potential triggers, because arresting those actually forms the fundamental crux in managing a case of mastocytosis. So you need to look for history of potential mast cell degranulating stimuli or the triggers. Now, the commonest triggers are physical triggers like friction or rubbing, use of alcohol and alcohol triggering an episode, food, multiple types of food, especially preservatives, additives, and coloring agents. And in the Chinese food or the Ajinomoto, the monosodium glutamate containing food, tomatoes, peanuts, pineapple, shellfish, egg, etc. are also other food which are being implicated in probably as a trigger. Drugs, very common and very important to know. NSAIDs, plasma expanders like dextran, opiates, then anticholinergic drugs like hyoscine or atropinogic drugs, non-depolarizing muscle relaxants like atracuril. Now, the importance of this is that these are the drugs which are probably one of the basic things in in your general anesthesia. So that is one of the importance. When a patient goes for a surgery, you need to be extremely careful when you send the patient, and you should mention that this patient has got so-and-so. You should be careful about taking so-and-so drug. Then radio contrast media, extremely important, because when you go for a contrast imaging, allergens like latex and plant products, and then the insect and the snake venoms. Venoms are extremely, especially the wasp sting, are supposed to be one of the very common thing. Now, how you diagnose? I had already come, but the most common diagnosis in cutaneous mastocytosis, histopathology, and you do a skin biopsy. There are a few things to be careful. You should, there will be minimum tissue manipulation when you take a biopsy. You preferably use a non-tooth forceps. You actually give a local infiltration around the lesion, not into the lesion. So there has to be perilesional local infiltration and take a biopsy and minimum manipulation. Otherwise, there occurs mast cell degranulation. Now, in a skin biopsy, classically, it will show, epidermis will show increased basal layer melanization. Dermis will show increased mast cells, which are oval or spindle shaped with a routine GIMSA or a routine stain. And the mast cells will concentrate around blood vessels and the appendages of the papillary dermis. And if you do a Tully in blue, it will show metachromasia with alkaline dyes. And then you can do a serum tryptase estimation, extremely important. A persistent elevation more than 20 nanogram per ml is diagnostic of mastocytosis. You can do an ISC staining with c-KIT or CD1117 and other things which I mentioned earlier. Now, there is a WHO criteria for systemic mastocytosis. You have your major and minor criteria. The major criteria, I'm not going to detail. It just means a dense infiltration of mast cells. And the second criteria is the involvement of other cutaneous organs, which is confirmed by tryptase immunochemistry. Minor means mast cell infiltrates more than 25% spindle-shaped cells, and a c-KIT mutation, which is described in the mutational analysis. Then expression of CD2 and CD25, serum tryptase more than 20 nanogram per ml. Now, this is something which you should know. And a diagnosis is made if one major and one minor or three minor criteria are fulfilled. Now, systemic mastocytosis, as I earlier said, majority are indolent. The small proportion which is aggressive or advanced are due to the mast cell burden or the mast cell leukemia, which we say, and the presence of additional hematological neoplasm actually complicates the issue. Now, the gain of function mutation also I had mentioned earlier. Prognosis wise, I said there are different prognosis and why the leukemic part, but there are certain prognostic factors which actually give you a clue whether the patient has got a good chance of survival or whether the prognosis is poor. One is age more than 60 years, serum alkaline phosphatase more than 100 units per liter, tryptase either equal to or more than 125 nanogram per ml, leukocytes more than or equal to 16,000 per millimeter cube, hemoglobin less than 11, actually less than 10 gram per deciliter, and platelets less than 1 lakh. Now, these things could act as a prognostic factor, and the mutational analysis also. These are, I've just put in this because there is something called B findings and C findings. Now, B findings are actually reflect the disease burden, but without any organ dysfunction. So a better prognosis. Like C findings, disease burden with organ function. All you need to know is that the percentages and all you can probably read up. That is, there is more than 30% mast cells on the bone marrow biopsy, and serum total tryptase is more than 200 nanogram. But what you need to remember is that in B symptoms, the peripheral smear will be relatively normal. There will be normal or slightly abnormal blood counts only. But while in C symptoms, there will be significant bone marrow dysfunction, and you can see HB is significantly low. There will be multiple cytopenias. There can be lymphocytopenia, leukopenia, and thrombocytopenia. Now, regarding the organs, in B symptoms or B findings, you can have hepatomegaly and splenomegaly without any clinical or lab abnormalities, and you can have lymphadenopathy, which sometimes is detected only on imaging. While in C symptoms, you have hepatomegaly and splenomegaly with significant clinical findings. That is, there will be impaired liver function, there can be ascites or portal hypertension associated with hepatomegaly, splenomegaly with significant features of hypersplenism, and you can have other features like in C, you can have intestinal malabsorption with hypoalbuminemia, weight loss, extensive anasarca, and you can have osteolytic changes more than 2 centimeters. Now, this is where one thing is important. Osteolytic changes are now actually being taken out of the criteria. So that is where I said you need to always update yourself with whatever is happening with mastocytosis. Now, how will you evaluate? The basic clinical assessment I've said, the presenting complaints, the allergic symptoms and system. You can actually look into the image and see that the both basic complaints or basic features are due to either the mediator release or the mast cell infiltration. So you can have general features of fatigue, weight loss, CNS, you can have headache and altered cognitive function, itching, urtication, bronchoconstriction. And the CVS, you can have flushing, syncope, hypotension, and tachycardia, abdomen, peptic ulcer disease, abdomen pain, nausea, vomiting, diarrhea, all the symptoms of malabsorption. Bone, you can have bone remodeling. While in mast cell infiltration, you can have lymph node enlargement as a general feature. In skin, you can have the different features like mastocytomas and diffuse as well as auditory. In abdomen, you can have hepatosplenomegaly, impaired liver function, malabsorption, and all the other features. In bones, you can have bone marrow lesion, hematologic disease, and the skeletal lesion like osteoporosis and fractures. Investigation, mandatory ones. Again, this is again a recap. Mandatory is a skin biopsy, doing blood counts to look for the type, cell lineage and cell amounts. Biochemistry, serum and urinary histamine are usually increased. Serum tryptase levels, and that is something which is considered to be significant, which has to be mandatory. Now, optional investigations are because of the systemic involvement. If the patient has got eosinophilia and tryptase more than 20, then you do a bone marrow examination with KIT mutational analysis. Chest X-ray, X-ray long bones, bone densitometry are optional investigations, especially in systemic type of mastocytosis. Ultrasound abdomen, including all the scopies to look for and GI imaging series to look for any involvement. Now, the treatment options are multiple. The fundamental thing that we can do is the prophylactic prevention of all the mast cell degranulation triggers, antihistaminics, both H1 and H2, mast cell stabilizing drugs like disodium promogloicate and ketotifen for cutaneous and disodium for the systemic type. Phototherapy, either your narrowband UV or your photochemotherapy of PUVA. Topical corticosteroids for isolated lesion and systemic corticosteroids when it is not managed. Now, another important option that is used when you have significant mast cell burden is what is called as cytoreduction or reducing the mast cell burden. Now, that is done using interferon alpha 2A and 2B and cladribine. Now, cladribine is the one thing which is universally followed in the West, but now it is being slowly taken out because of its bone marrow toxicity and other toxicity profile. So the onus is now on looking for are addressing the pathogenesis. So what is fundamentally happening? A KIT mutation, which is happening. So we are trying to look for a KIT inhibitor. The first thing that was used was the tyrosine kinase inhibitor, imatinib. And because of it being non-selective and non-specific to the drug entity, it has been slowly removed, and they are looking for KIT mutation of the CD117. Now, for that, the first drug that came in was midostaurin in 2017, but it was relatively non-selective and associated with significant GI toxicity. So more of literature went in for specifics, or more of studies actually went in for specifics, and now they have come out with what is called as avapritinib in 2021 and 23. The different FDA approvals were got. It is a potent and very selective KIT D816V inhibitor, a specific inhibitor. But again, avapritinib, over a period of use in the West, they have found that the patients are noticing significant amount of cognitive impairment. So again, a search for next generation of highly specific, less toxic, drugs with less cognitive impairment has been going on. And there are two which have been relatively found to be very effective, plus less of cognitive impairment. They are not completely approved, but they are in the phase 3 to phase 4 trials. They are the bezuclastinib and elenestinib, which have minimal blood-brain barrier penetration, so less of cognitive impairment. They are highly selective. And in case of those which associated hematopoietic malignancies, there is an option of allogenic hematopoietic stem cell transplantation, which is happening. Now, this is just about what a therapeutic overview. If the patient has got pruritus and flushing, you go for H1 and H2 antagonists. We can give leukotriene antagonists like montelukast. You can go for topical glucocorticoids. NSAIDs can be given. Mind you, it is a paradox. NSAIDs themselves can act as trigger. Sore lens, including PUA, if the symptoms are refractory. Omalizumab has been tried if there is an IgE elaboration. In hypotension and anaphylaxis, intramuscular epinephrine. Now, that is one thing which is there. Patients with known history of anaphylaxis are supposed to carry what is called as an EpiPen or an epinephrine pen, which they can use in cases of anaphylaxis, which otherwise can prove fatal. Then you can have cytoreductive therapy, I've already mentioned. On top of that, you can have your in peptic ulcer disease and all. The rest, I think I've already mentioned. I think these are things which I've just put it as a summary. I think we are running short of time, so I just rush through. Now, finally, how will you follow? Now, one thing is important is that once you make a diagnosis, in cutaneous mastocytosis, all you need to look is for addressing the trigger and keeping the patient under regular follow-up, and you can gradually increase the period and tell the patient to come, because it is relatively benign and has got a good progress. But in systemic mastocytosis, it is mandatory that you keep the patient under regular follow-up. You need an annual checkup of the blood counts, the biochemistry, especially the tryptase. And those with some amount of bone change, it is also mandated that you have a 3-yearly bone densitometry. I think with this, we come to the end of the lecture or the discussion. What I've been trying to give is an overview of mastocytosis and the fact that how it can be benign and malignant. We as dermatologists are most likely to see the benign or in the childhood, the urticaria pigmentosa line or the maculopapular type. But mind you, there is a systemic one also, which early detection might help you to treatment. And there are treatments which are coming up the line. Many of them are not available for us, but those which are available can be used if we make a detection early. And the need for keeping what is most important is that I always believe that we try to make use of what we have. So what we can do, a proper history, and try to address the potential triggers which are there. And so a very detailed history with the child, if the child is giving a history, or with the parents, with the parents also is mandatory, so that we try to identify some trigger, and addressing those triggers will go a long way in managing the case. So I think with this, we come to the end. I thank Criton sir again for giving me this opportunity. And I also thank Lodama for all the help rendered. Thank you. Thank you, sir.
Thank you, Dr. Bifi. It is an excellent talk. And I think most of the postgraduates have benefited out of it. And of course, they need to read once again, so that what you have said in the lecture, may be remembered, and when a question is asked, then it will be easy for them to answer the question. And for the purpose of question, university examination, this is often asked as a question. So be careful and read and study. Thank you, Dr. Bifi, once again.
Thank you, sir. Thank you, sir.
We extend our gratitude to the speaker, Dr. Bifi Joy, sir, to have given lucid presentation for the benefit of the PGs. And also, we extend our heartfelt gratitude to Dr. Sebastian Criton, sir, as conducting continuously more than 2 years for the benefit of the PGs. Across India, all the PGs are getting benefited. And for the PGs information, the recorded version is available with our Research Pharma website, edited version in our Research Pharma YouTube channel. So you can contact our people to get the link also. And moreover, kindly share this information to for the benefit of your colleagues also. Let them also benefit it in the forthcoming programs. So Research Pharma finally committed for the academic session forever. Thank you so much, Doctor. Have a good day to all.